Welcome. My name's Lou Irving. I'm a respiratory physician at the Royal Melbourne Hospital, and I'm your chair for the first session this morning. Before starting, I want to acknowledge the traditional custodians of Australia. I pay my respects to their elders, past, present and emerging. I also want to highlight, and as healthcare workers, we're very conscious of this, but there's the ongoing pain of the loss of land that occurs for Indigenous Australians, and to let them know that we're thinking of them. Last night in opening the meeting, I highlighted that for the last 30 years we've been meeting, this time every year, to discuss ways of reducing the burden of respiratory infections through understanding the science of immunisation and to promote immunisation as a public health measure to reduce the burden. And every year, up till this year, about 120 people with a broad range of expertise have been meeting, and that expertise has included GPs, hospital doctors, public health physicians, epidemiologists, basic scientists, immunisation nurses, pharmacists, government policy makers, industry representatives and patient advocates. This year is different. Firstly, we're not meeting face to face, we're online. Secondly, the highlight will be on COVID, the new emerging respiratory infection, although we will also cover influenza and pneumococcus towards the end of today. And the third difference is that there are many more people online. So we've got over 400 registrants, and many of the new registrants are nurses involved in rolling out vaccination. So welcome, and thank you for attending, and thank you for your efforts in the next few months. Our first session it has three very expert and interesting speakers, and our first speaker is Professor Rhema Vaithianathan. Rhema is Professor of Social Data Analytics and at UQ, and Professor of Economics at the Auckland University of Technology. And Rhema's going to talk about the role of digital technology in COVID-19. Rhema, welcome, and thank you for your presentation.
Thank you everyone for joining at this Monday morning. I hope things are going well for you wherever you are and you're staying safe. I'm speaking from New Zealand, but I'm going to share some of my experience trying to work on digital contact tracing in the context of the COVID-19 pandemic. So it's a little bit of a convoluted story because my area of expertise is not digital contact tracing, and I'm sure almost everyone I worked with at the time, none of our areas of expertise was digital contact tracing. So I just want to tell you a little bit about myself. I'm a health economist by kind of history, but more recently I started a center called the Center for Social Data Analytics, which has two hubs, one at AUT and one at University of Queensland. And I think the reason we got involved in digital contact tracing was that we have done a lot of work in quite high stakes government technology deployments. In particular, we've been working now for a number of years in the US on deploying child abuse predictive algorithms, which are probably some of the most sort of controversial areas to use machine learning tools. Our work's been covered in the New York Times, in Nature, in Netflix documentaries, and so on. And I think what people saw in our work was an ability to not just develop algorithms and machine learning tools and digital products, but to also translate those into usable and, more importantly, socially accepted deployments. So one of the challenges in our new technology area is that a lot of the problems are not technological, but they're social technological. So I was invited by colleagues at NHSX back in 2020 March, because they had been commissioned by the government to lead the work on developing a digital contact tracing app. And because our Center for Social Data Analytics does a lot of work, not just on public good technology, but also on safeguards, ethics, social license, community engagement, we were brought in to try to give some advice to NHSX about how they could potentially take the technological ideas that really had come out of Christoph's work in Oxford and Christoph Fraser's group in Oxford, and try to see how we could work on making those tools something that could be rolled out in the context of the NHS. So before I start talking about my experience, and actually as a result of that work with the NHS, we ended up also kind of being part of a group for Europe-wide, because France and Germany, Ireland, Denmark, they were all looking at digital contact tracing at the time. And then we also got involved naturally in New Zealand and Australia. And this is about the time that the COVIDşafe app came out. We were advising some of the states on what their alternatives were for digital contact tracing. So that's the context in which I speak today. It's very much about that time. It was very, very, as you can imagine, a lot of pressure, a lot of time pressure, a lot of urgency. It was March 2020. We didn't know what was going to happen in any of these countries. We didn't even understand how contact tracing, digital contact tracing could work. But people were pretty optimistic that the technology could really help. And I think Christoph Fraser's work had suggested that this was possibility of a new technology coming in to really save the day. And a lot of ministers and prime ministers, right from Boris Johnson to Australian Prime Minister, and Angela Merkel, they had all announced that these were really important technologies that were going to really help their countries address the pandemic. So it was quite high stakes, quite politicized environment in which we were trying to filter through advice. Just for those who are not familiar with what digital contact tracing is, digital contact tracing is basically using a Bluetooth possibility in mobile phones. So what it does is when two phones come to be in proximity to each other, if both of those phones have an app installed in them, the theory was that if they were within 3 meters of each other, they could do what's sometimes now called a Bluetooth handshake, where they basically can exchange each other's ID. And so they had this idea that because that would then hold in each person's phone a record of all the other phones they had been in proximity to, this would allow you two things. One is to be able to identify casual contacts, people that a contact tracing traditionally has a lot of difficulty in finding. The second is that it would also automate an alert system, so people could be alerted very quickly, because on their phone would be a history of all the people they had been in contact with. And if any of those people tested positive and became a case, then the person with whose ID had been retained in a contact's phone will be alerted to say something along the lines of, you have been proximate to a contact and you should immediately, call local public health, or and certainly isolate yourself. So that was the concept, and it was quite valuable for this particular virus because of the very strong need for speed, as you probably know. At the time, we didn't have a lot of information about asymptomatic transmission. But what we did as a team was try to pull together some of the research that had already come out and try to give a really simple diagrammatic explanation of what the case was for digital contact tracing. And this is sort of what we came up with. It's simplistic, but it allows people to understand why, in the case of COVID-19, you really do need speed and need the types of speeds that at the time we thought was simply not possible for manual contact tracers. So here we've simulated multiple curves based on reproduction rates ranging from 3.4 to 0.5. And the concept here is very simple. It says, suppose the case is isolated, but it takes a few days after the case becomes symptomatic to trace all contacts and isolate them. How many infections would those first order contacts have spread before they become isolated? So this is basically saying that if you take someone on the first day of symptoms, they've already transmitted the infection to others who have then gone on to infect others. So there's nothing you can do about time zero. But what this tells you is that by the second day after symptoms, if for example, thinking of a reproduction rate of 2.5, if you take on average of 2 days after the onset of symptoms, not after positive test results, but after the onset of symptoms, to find all first order contacts and isolate them, those first order contacts would have already generated 1.5 additional infections. So it sort of gave an idea of that sort of need for speed and the fact that after 4 or 5 days, there really wasn't much marginal value in finding and in contact tracing. So contact tracing had to happen super fast, and it had to happen within this window. So the first case we try to do is to try to simply tell that story of why this particular infection was controllable, but controllable with high speed. I mean, it's the work based on Christoph Fraser's work, but they were much more a complex model. And we thought, first of all, we need to simplify the story to make it more accessible to the community. The second thing that we really try to emphasize in our work, that we try to get ministers and others to understand, is that whilst speed is of the essence, so is take-up. And I think one of the things that was really missing in the conversation was people didn't understand how important take-up was. So again, to try to make it really simple and accessible to ministers and officials, we sort of generated these kind of hyper sort of ISO curves, really. So the concept, again, is very simple. Suppose you are going after a 72-hour target delay, right? And you want after 72 hours of the onset of symptoms, all first order contacts to be bundled up and isolated. Then, of course, you could do that. If your manual tracing times are 3 days, then you don't need, with zero take-up of app and a 3-day manual contact tracing time, you get 72 days. If you've got an 80% uptake of the app, your manual contact tracing can on average go up to 10 days and you'll still get a 72-hour delay in your in isolation of first order contacts. So what this tells you is that really right up to 60% of app take-up, you're really not getting a lot of value. It's only after because it's an increasing returns to technology, it's a scale technology, you really do need very high levels of take-up in order for the app to actually contribute anything to that essential need for speed. The third thing that we try to identify and emphasize is that this problem that the governments had around the world was not a technology problem, but it was a social license problem. The problem was to get those kinds of take-up. You needed what our team calls social license, which is when people trust that their data will be used as they have agreed and accept that there's value to them, then they are likely to be comfortable with the use of their data. The fourth thing that we emphasized was that these rollouts of these kind of very high uptake technologies, you're wanting a very large percentage of your population to accept and see value in what they're being offered. And of course, you can see very similar challenges to our immunization problem. You're going to have to understand what low trust communities need in order to be assured. And we felt very concerned with some of the governments that we had been having conversations or seeing, that they were focusing on the more businesses, on how employers could use these apps as almost a threat. And we felt that was really undermining the trust that people could have in this technology. As a group who do a lot of technology deployment with very low trust communities, we work a lot with Black and African American communities in the US, Maori and Pacifica communities in New Zealand, trying to understand concerns they might have with the use of algorithms and machine learning tools. We've been very conscious and acutely aware that it is indeed the low trust communities that one needs to really emphasize when one is trying to get community-wide acceptance. Relying on high trust communities to take up your technology will never get you the kinds of uptake that you need for these sorts of broad and I'm sure with public health people in the audience, I don't need to tell you that, but unfortunately, because this was very much a technology deployment, the technologists are very much driving the deployment and they didn't necessarily understand that concept. And of course, we've always believed in our work that at the end of the day, people want to understand benefit. And to be clear, when we worked with especially Indigenous communities, communities of color, that benefit might not be a benefit to them as the individual, it might be a benefit to them as the family or whānau, as it's called in Māoridom. It could be the benefits to people in their community, but people still want a clear and valid articulation of the benefits to them and their people. So the only way we believed that this could all come together with these sorts of digital technologies is to commit to a very good evaluation strategy. And unfortunately, none of the agencies who we met or had any conversations with seem to understand that these sorts of apps, very much like vaccinations, is what in economics is called a credence good. What a credence good is a very unusual type of good. The giver, the seller, will assure you that it has done some good to you. But actually, you can often never know if you have received the good. So when you have an app, you will never know whether that app is working because it could very well be you've never been in contact with someone with COVID-19. Similarly, when you get immunized, you might never know whether you truly have the immunity or not. You might know when you don't, but you might never know that you do because you could just be lucky. So credence goods require incredible level of trust, and to encourage and engender that trust, we argued that governments ought to pre-commit to a strong evaluation strategy, and no one really did that because we felt that consumers needed to know that the uptake of apps had been working. They needed to know how many people had been alerted, how many contacts had been traced, and how many infectious had been avoided. So turning to our own Australian version of this technology, I'm going to possibly teach this as really a case study in government technology failure. And the reason I say this is because over the time of the rollout, I sort of saw everything that in our decade of work with the deployment of technology for public goods, we've, all the errors sort of cascaded one after the other. And that's completely understandable because it was done with such high pressure and under such circumstances that you could understand why people really struggled, but it really was a case study. So first of all, I felt that COVIDşafe was seen very much as a technology solution by government when it really was a social technical solution, which required a clear communication strategy and a clear community buy-in. There was definitely a level of over-promising and at the highest level, which really concerned me because the whole management of COVID-19 and the immunization and the vaccination program is going to require a lot of trust. So I felt that every statement that leaders made in this pandemic ought to be backed by really good evidence. And I don't quite know why that happened, but as you can see from our pictures, app take-up needed to be much higher than had been advertised at the time. I think part of the challenge was federal agencies at the time didn't understand the technology. They hadn't got on top of it. They hadn't got on top of contact tracing and how this technology contributed to that. And so that led to really what was a poor choice to go with the Singapore code when there was clearly an Apple-Google solution that was being developed and waiting in the wings that was going to work much better. And it was clear even at the time that the Singapore code wasn't working. You just had to go and look at the App Store and look at the commentary in the people who were using the Singapore app, all the problems they had, because the problem with iOS is that when the app runs, it starts running in the background very quickly if your phone is not in the wake mode, and it basically refuses then to do that Bluetooth handshake. And that was clear. It came up much clearly afterwards that that was a problem, but at the time it was really clear, and certainly the researchers we were talking to knew the problem. And unfortunately at the federal level, there seemed to have been a pre-commitment to this without any subsequent work to address that. And I think there was also a poor coordination with state public health, and we see that a lot in deployments, is that people don't, when they deploy technology, they sort of think people have become kind of fixated that technology is the solution to everything. They've become the new shiny piece of tinsel that governments reach for all the time. And I always say to people, just because Uber can get you from your house to work doesn't mean that some of these grand challenges are equally amenable to that kind of over-technologizing approach. Technology has its role, but you have to see it in the context of a social technical problem. And so I think what's happened is people and governments have become incredibly sort of excited by technology. They're being sold a lot of technology, a lot of sort of startups, a lot of cool people, sitting on orange, sofas, have told them that this is cool. And so they've sort of started really driving technology as a solution to grand challenges like pandemics. And so I think we just need to recourse ourselves and think about where technology is good and where it isn't. And so the natural conclusion of that is that it really didn't work and had a lot of negative. But just to be clear, Australia is not the only only failure. There are multiple countries for whom it didn't work. Even Germany, who for many months we really tracked as one of the sort of outstanding examples of this. Unfortunately, the challenge for Germany is that they went with the Google's Apple, the decentralized app, and so the impact of the German app was not able to be evaluated. So there's a lot of challenges to actually saying, yes, countries that had high take-up, it worked. It really is a very challenging problem. So I sort of in conclusion, I suppose, when I reflect upon it, I don't think any of us had it right. I was overly optimistic as well, I have to say, about the ability of digital contact tracing. But I think in the end of the day, people have to make a credible case for the technology and really look very carefully at technology. You don't have to take a lot of time to do it, but you have to be incredibly sort of pessimistic optimist. You have to be pessimistic about the deployment, but optimistic about the technology, and then see how you can make the best of it. Choosing the right technology is always a challenge for governments. Governments are always behind, and partly I think it isn't that they're naturally poor choices, it's that they don't always bring all the right voices to the table. They don't bring the people who know the social part of the problem as much as the technology part. Partly it's because they're driven a lot by private sector technologies, which certainly the Australian app was. And private sector technologies are used to selling technology to consumers who see value in it and want to buy it. Technology in the public sector is not like that. Governments impose it on communities, not all of whom might see a benefit of it. So it's the difference, it's chalk and cheese, the world of voluntary technology purchase and the world of technology for public good. And what I've noticed is that when you have private sector technologists crossing over to public good technology, they don't understand the essential part of the social contract that goes with public good technology. And so they kind of, the inability to navigate the social contract, the social license, the social technical part of it often means that even however shiny and bright the technology is, it sort of fails to have impact on the actual social problem they're trying to solve. So I think these are all really valuable lessons that we've all learned. And I hope that those are lessons that we will carry forward to next time we have a technological opportunity like this and not make the same mistakes. Unfortunately, I think we'll just make a whole new set of mistakes, but possibly not the same ones. So thank you very much for your time. If you're interested in what we do look us up on our website and follow us on Twitter.
Rhema, thank you. Terrifically stimulating talk. I think there'll be lots of comments and questions about the need for speed and social license, low trust communities and the failures of COVIDşafe. Our next speaker is Professor Jodie McVernon. Jodie is a public health physician and epidemiologist. Jodie is head of epidemiology at the Doherty Institute. She leads a highly expert group who model infectious diseases. I must say that Jodie's modelling of COVID activity in Melbourne was very reassuring and helpful for clinicians. And that's really the title of her talk, of how modelling can inform other groups. Thanks, Jodie.
In the next 25 minutes or so, I'm going to try and talk a little bit about how modelling can be used and has been useful to support decision-making in uncertain times. And it's been an interesting year for modellers because we now know that 50% of the population is actually modelling, but it's been extraordinary to go from being somewhat on the side to hearing the Prime Minister talk about our effective. What I want to cover off in the next little while is really just to explain how modellers think, when models can be useful, and by going through some of the applications, I guess, just to demonstrate that and how they have supported decision-making and insights and policy. And then to talk a little bit about our future options and what the emerging challenges are. So as an epidemiologist, I'm an epidemiologist before a modeler. I very much like to go back to the WHO definition of epidemiology, which is the study of the distribution and determinants of health-related states or events, including disease. So we don't just look at disease data, we look at other forms of data that can help us to understand the drivers of changes in health conditions. And then, of course, our motivation is to apply that study to the control of diseases and other health problems. And as infectious diseases modelers, we start with this really quite simple SIR paradigm. So when we think about an infectious disease, we can characterize an individual in the population as being either susceptible to it and not yet having acquired it. If that person comes into contact with an infected and infectious individual, there is some probability that they will become infected and infectious themselves. And following a period of infection and presuming that they don't die, which is another potential outcome, they may recover and potentially over some period of time be resistant to reinfection. But for many infectious diseases, that immunity wanes, and so people go back through the loop. And by this fairly simple paradigm that was published and reported in 1927, so it's very cutting edge, we have quite a simple mathematical construct that allows us to understand the rise and fall of epidemics. The most critical part of this is this feedback loop here. So if we think about at any single point in time, we can divide people in the population up into these boxes if we could observe their state. And the people who were sitting in the infected and infectious box, that is the prevalence of infection in epidemiologic terms at any point in time. But this feedback loop shows us that as the prevalence of infection increases, the rate of flow from susceptibles to infectious people, so the number of people becoming infected per unit time, will increase. And this flow from susceptible to infectious is the incidence of infection per unit time. So there's a positive feedback loop. So if there's one infected person in the room, they may infect a couple of others. If there are 10 infected people in the room, the absolute number of new infections will increase more per unit time. So those things are related. And that's important because in having these mechanistic models, these events are not independent, which is the basic requirement of statistical models. They're exquisitely interdependent. And by thinking about these mechanisms and processes, we capture that interdependency. And of course, as people move from left to right and go from being susceptible to infectious to recovered, we get to a point where there just aren't enough susceptible people around to keep an epidemic going. So it's a bit like a bushfire and fuel. Once you've burned through your fuel, you don't have enough there to sustain the fire. And so this is how epidemics can resolve before everybody in the room gets infected. And the point at which that happens, so the proportion of people who will become infected before the epidemic dies out, is related to this beta, if you like, this transmission probability. It's something about how many secondary infections each infected person is going to make and how many contacts they're making. So we end up with this concept of the reproduction number. On average, how many secondary infections does someone make? And if we think about a disease like COVID, where that number is somewhere in the order of 2.5 in a completely unconstrained epidemic in a completely susceptible population, we can use the maths to say, well, 60 to 70% of the population will need to be infected on average before this dies out. And we can layer in the things we know. So this is the simplest formulation, but these layers are added over time and need to be justified by their need because we need to keep things as simple as possible. But individual variation can determine how susceptible people are. The rates of social contact will vary by age or by social group or by population, and that will determine how rapidly the infection grows and its ultimate size. And in thinking about this phase from infectious to recovered and what's happening there, we need really detailed biological insights into the host-pathogen interaction, and particularly around this issue of maintenance of immunity. And by layering in that additional knowledge, we need to draw on all of the available evidence from a range of disciplines to be able to better characterise what happens next. And with increased computational capacity and as data are available on social and contact patterns and mobility and social structures and so on, we can take that very simple construct and layer it further by representing that SIR process at the level of an individual. So we can have individual-based computational models that characterize that process. and then see those individuals within a wider social and demographic construct. So we can put those individuals into households where they will have a certain contact propensity with their family members. They may also relate to others in the community in a certain way, and they will have differing access potentially to medical care and resources. And so by building these more complex models, again, they must be validated by data and motivated by a question. We can address more granular issues about why some groups in society are disproportionately infected, how targeted interventions might work, where best to optimise the use of strategic resources to minimise harms and suffering. So there are lots of different ways that we can make these models more realistic, if you like. The challenge then is making it clear to people that they're not real. This is a simulation, and these are thought experiments, and they're ways of thinking through and supporting decision-making about a problem. But it becomes something that can more approximate real world to help that fine-grained decision-making. So how have models been used? And I guess the first use of models is to look back and to analyze data and to try to make sense of the emerging picture. And as a modeler and epidemiologist, one of the striking features of COVID was that so much of the data that we had access to early on was from news reports and the web. WHO started convening modeling calls in mid-January 2020. We kind of got that this was going to be a problem back then. And a lot of the very early analyses of what was happening in Wuhan as a new infection was emerging there was all about understanding mobility. So at a point where there were 44 cases of severe pneumonia in Wuhan, 3 or 4 individuals were identified in other countries around the world. And based on global data on travel and transport, which had been collated over many years, largely motivated by the need to study influenza, it became clear that given that degree of exportation, that there were already thousands of cases of this new virus in Wuhan at the time. So it was a way of using a non-traditional form of data in health to unpack the limited evidence that was available. Similarly, some very other influential early pieces of work. The group from Hong Kong were invited into China to look at the line lists of the early cases that emerged in Wuhan. And from that and from a number of other studies since, these critical parameters determining those rates of flow between the boxes that we saw started to become clear. And so these were our first estimates of that basic reproductive number, which is so important for understanding what the final attack rate of an epidemic is expected to be. One of the other very critical analyses at that time was a work showing that even though Wuhan was locked down very decisively, that a delay of even only a few days would have allowed infections to escape more broadly through China. And this paper was very influential in Australia in making the decision to close our borders with all of China, even after Wuhan travel had been ceased. Again, going back to that early epidemic data, really rich information from paired observations of infection. So here we have a graph showing a number of rows in green of paired transmission events. The green bars represent the periods of exposure between the primary case and the secondary case. The red dots show the onset date of those cases. And from this, again, more critical information about these epidemic parameters. How long did it take from the infection of one individual to another, this serial interval that tells us how quickly things are moving. How long were infections lasting, which is obviously critical to isolation recommendations, but also what on average was the delay from one case to the next and what was the tail of that, critical for quarantine recommendations. And the very compelling question early on, was this an influenza-like disease where much of the transmission of infection occurred before symptom onset, which we know makes an infection much more challenging to control, or would it be like SARS or MERS and predominantly infectious after the onset of symptoms? This was one of the first analyses that suggested that pre-symptomatic transmission was possible. And as we have become better at testing, treating, isolating, and making sure that those individuals with symptoms do not transmit, this has really revealed the proportion of asymptomatic transmission that does occur. And this is why quarantine is such an essential intervention, that individuals prior to onset of symptoms are contained so that they do not become unknowingly infectious to others. One of the key cognitive biases we had in this pandemic was, our deep belief that children are the agents of evil and certainly the sources of biological terror. And for most infections, that would be true. But there was a very striking absence of school outbreaks early in the COVID pandemic, unlike 2009 H1N1 that was totally fueled by children and school-based outbreaks. And this was challenging, and this particular analysis, we don't need to go into every graph on the slide in detail, but on the left we have age-based incidence of COVID from many, many countries in the world. And while the distribution of disease in elderly on the right changed in many settings, the consistent feature everywhere was this apparent very low incidence of infection on the left in the youngest age groups. And that could be down to, one of two or potentially contributing things. Either children were less susceptible to acquiring this disease or simply less symptomatic with this disease. And this early analysis from the London School really tried to tease those things apart. And while it was clear that children were less symptomatic and therefore less likely to be picked up, it also was inferred from this modelling that they were less likely to catch the infection out in the community. We know that in close household settings, children are both able to be infected and are infectious, but repeated outbreak assessments within the school environment that really try to closely assess the likely rate of spread between children outside the household has confirmed over time that this is not a primary source of spread, which means from a disease control perspective, we anticipate the role of school closures to be less than for an influenza-like illness, and also the role of vaccinating this group. They're not the key transmitters, so we would not expect to see the benefits that have been observed, say, in the UK with school-based immunisation strategies. And then, of course, how long do people stay resistant and recovered? And so, ongoing studies of immunity, ongoing studies of cross-protection, which we'll come to, how long will this immunity last? And so those who espoused the herd immunity option back in early 2020 as, our way of just getting through this and to the other side, must now be rebuffed by the experience of Manaus in Brazil, where, following a catastrophic first wave in 2020 with mass deaths and zero exposure rates of 60 to 70%, regrettably, Manaus is having all the same thing again. So this issue of population persistence of natural immunity is still something that we're learning about. So how has modelling been applied in Australia? Well, I'll just give a few examples that sort of chart some early decision making. But way back at the beginning, back in early 2020, when China was essentially the net exporter of infection, it was the primary source. And we had banned travel with China, Australia still had to make ongoing decisions about travel from other countries in the region. And early analyses had already shown that, Sydney and Melbourne were two of the 20 most connected countries, cities with China. And so our propensity for travel from that direct route was very high, but we're also interconnected with other countries in the region. And at this stage, while travel had been reduced, it was still ongoing. This work that was led by James McCaw with Freya Shearer and Nick Golding and David Price and others put together several models that were in place at the time to understand from persisting travel what was the risk of importation of infection from China to these intermediate countries based on what was expected to have been exported there and what the countries were reporting, how many cases might actually have been missed. If cases had been missed as time accumulated, the probability of an undetected outbreak in those countries was increasing over time. And based on that, what was the likely importation risk to Australia? And this sequence was important because some countries were reporting no cases, other countries were reporting many. But, Singapore was estimated, for example, to have a very high rate of detection of all of their cases, whereas other countries, for example, like Indonesia at the time, were reporting no cases, but it was highly likely that cases were there and not seen. And so this risk assessment was updated regularly in the months of February and March to help inform, who to test and who to screen. So, when a clinician sees a patient, who should they be concerned about? Who were people of interest? To inform travel and border recommendations, to inform DFAT advisories, and to try to think about our connectedness. And obviously, since that time, we've ceased all travel, but this kind of process is something that we're going to need to go through again and continue to assess risks from other countries as we think about our borders moving forward. Another piece of work that was influential, and these things are often misinterpreted, was a piece of scenario preparedness work. So this was work saying if in Australia we had a widespread outbreak that had the epidemic growth features of what has been observed overseas, what would be the likely clinical impact based on transmissibility and severity? How would that relate to the capacity of our healthcare system? And Rob Moss led this work based on earlier work that had been undertaken for influenza that was adapted to COVID, to say, well, how does this actually relate to the capacities of our primary care and our hospitals and our intensive care departments? What might measures do to reduce the overall growth rate of the epidemic? At that time, we really did not know just how public health and social measures would be able to constrain this. And so we looked at the impact of contact tracing and quarantine and isolation within the model as a way of suppressing the outbreak. We also, with that, showed that even if those measures could be sustained throughout an epidemic, and we've seen the challenge in doing that, and we've heard some of the technological solutions that were proposed that were not effective, would that still be enough? And we said, well, that still won't be enough because we have this pre-symptomatic transmission phase. And so the model then looked at how additional social measures would be needed to support the public health intervention to overall flatten the curve, which was the saying at the time, and to keep this whole epidemic within what was a safely achievable expansion of capacity. So these models weren't used to say you need to go and buy this many ventilators. They were used to say, will this exceed what we can reasonably safely do based on consultation with the clinical community? And by looking at that together, proposing that really a tripartite strategy was needed of clinical preparedness and expansion, public health strengthening, and ongoing targeted and in some cases widespread social measures to reduce transmission. And this really was the basis of strategy. And then as we started to see cases in Australia, we moved to the next stage, which was situational assessment and prediction of our own epidemic, which I'll come to in a minute. The other piece of work that we were asked to do was by the Aboriginal and Torres Strait Islander Advisory Group, because obviously one of the great concerns in Australia was that our First Nations populations, based on all of our experience of pandemics in the past, were at high risk of infection and severe outcomes from COVID. We've seen an extraordinary response led by First Nations Australians and disproportionately low rates of infection in our First Nations population, which is a credit to that work. And with that, we used some agent-based modelling approaches to think about the importance of early testing and early application of public health measures to control spread, which was part of the work that supported the rollout of the point of care access to rapid testing in remote communities where no community would have to wait more than 2 days for a test. And that work was led by Kirsty. So, all of these things, it comes to a specific question, a specific need, a model has to be developed to fit that purpose to address that information need. I mentioned too that we moved from scenario prediction, well, not scenario prediction, scenario consideration to actually situational assessment, and a body of work led by James McCaw with a group around the country. Nick Golding for our Shearer has been used to ongoing estimate what is actually happening around Australia with cases when they occur, to think about what's happening to the reproduction number. But because we're in quite a special situation here, we are in this privileged position of having really zero community transmission. How do we use these sorts of measures to understand the risk of COVID should a case be imported? And so this work talks about what we call transmission potential. So it uses ongoing behavioural survey data, looking at people's compliance with personal recommendations to reduce risk. It looks at mobility data on how populations are moving, how they are responding to interventions and policies. We see spontaneous behaviour change before policies are implemented. And so this work tries to put all of those things together and estimate, would an infection incursion to occur? What is the risk? And we see for different states and territories that have had different experiences of COVID and they're on different policy settings, we see that varies around the country in ways that are quite plausible and that are seen to respond to the policy settings. And in just back to the non-traditional forms of data, one of the really critical sources of information, so Facebook, Google, Apple have made mobility data available that have helped us to understand what people are doing. One of the very useful predictors is the Facebook data through their Data for Good program, and this particular indicator on staying put tells us how the stay-at-home recommendations are working. and how people's mixing in the community changes. And this particular slide shows changes in metropolitan Melbourne in purple and regional Victoria in yellow over much of last year, through phases when in the red here we were in different lockdowns. As measures were escalated, the proportion of people staying put increases. As those measures are reduced, the proportion of people staying put comes down. And we see in the second lockdown the widening between metro and regional Victoria, which were on different policy settings at the time. So it just shows how this data can actually really helpfully capture the population trends and give us feedback on the policy settings. And I won't go into this in much detail, but obviously those are past questions and we have emerging challenges. And as we embrace vaccines and think about how best to use them, models are being used. Here's an example from Michael Meehan, some work done to think about targeted and uniform vaccination strategies by age, and thinking about how vaccines that might protect against infection would give us much greater benefit than vaccines that would only protect against clinical disease. And again, this is something where we are learning from the population experience how to better refine these predictions and assumptions to help to guide optimal use of vaccines. And clearly that vaccine story interacts with the emerging variant story. So here is some early work from the London School analysing the potential underlying mechanisms that might have led the B117 strain to cause an increase in the incidence of disease over time, and basically coming down to the conclusion that this was a more transmissible strain. The data didn't fit well to other hypotheses about the mechanism of disease. So it's a way of trying to analyse these trends and know what they mean. And obviously that's then very important in feeding forward. And so the situational assessment work in Australia that's looking at this transmission potential, last week our Common Operating Picture, which is a weekly spreadshot produced by the Commonwealth, for the first time introduced the transmission potential for B117, so should that become imported, as well as the previously circulating variants. So just to sum up, really, epidemiologic models take in all relevant information about the drivers of disease, and that can be different forms of information and data, and we've certainly seen an expansion in the forms of data used over the past year. They can be used to synthesize available evidence, acknowledging uncertainty, to then guide decision-making for unknown futures. We know and continue to see that living with COVID is going to require a combination of public health and social measures into the future, likely alongside vaccines, and our challenge will be titrating those over the next year. And really ongoing analysis and evidence synthesis will be needed to support adaptive measures to overcome new challenges for disease control. And I'd just like to acknowledge many, many people who've been involved in this work that supported Australian government over the past year. Thank you for your attention.
Jodie, thank you. A fabulously clear description of modelling, how it's based on the biology of the disease and how it can be used to inform decisions. Jodie mentioned the SIR paradigm, and the S was for susceptibility, and the next speaker is now going to address susceptibility. Dr. Kirsty Short is an Australian Research Fellow at the University of Queensland. Kirsty leads a group investigating the pathogenesis of influenza and its interactions with high-risk groups such as people with chronic comorbidities. And she's ideally placed to talk about risk groups in COVID-19. Kirsty, welcome.
Thank you very much. And it's an absolute pleasure to be here. And yeah, really nice to be amongst such a stellar lineup. So I think we've heard throughout the COVID-19 pandemic a lot about the various different risk groups that exist. And because of the sheer number of risk groups that exist, today I'm just going to focus on those with metabolic disease. So very, very early in the pandemic, it became evident that individuals with some sort of underlying metabolic disease typically did worse with COVID-19. So these were just some infographics from New York and Louisiana looking at the top underlying health conditions in deceased COVID-19 patients. And you have things like diabetes, hyperlipidemia, obesity, hypertension, all these things that sort of we know are very, very prevalent in our society. But for a long time in the pandemic, we had a lot of questions about this. And some of the questions were things like, Well, when we look at, say, diabetes as a risk factor, how much of that is coming from diabetes itself, and how much of that is coming from the fact that often type 2 diabetes is commonly co-associated with obesity. So we had all these sort of confounding variables. And then on top of that, we have this problem where people were very much focused on obesity, which is certainly a prevalent problem, but there was very limited evidence looking at the effect of overweight, which, keeping in mind, there are a large number of people who are overweight than there are with obesity. So based on that information, we started, gosh, I can't even remember when we started this, sometime early last year, a big international study looking at the effects of both diabetes and BMI on COVID-19 outcomes. So we recruited and had clinicians, and it was just an amazing collaborative effort. Patient records from a variety of different countries. You can test your geography by seeing, you can identify, I don't know why that's going. Okay, get the slide through. Yeah, thanks. We're having some slide issues. Okay, good. So you can test your geography by looking at a variety of different countries here, but they included things like places like Indonesia, Denmark, China, Switzerland, South Africa, Austria. We tried to get a broad range of different countries. So just to have a look at how we measured this, what we did is we retrospectively extracted the data from healthcare records of hospitalized SARS-CoV-2 patients. And what we did is we looked at 3 particular outcomes for disease severity. So we looked at non-invasive ventilation, invasive ventilation, and mortality. And what we did, which was very important here, is we looked at the odds of each of these outcomes adjusted for various comorbidities, so age, sex, comorbidities like cardiovascular disease, chronic respiratory disease, and BMI. And then we combined the site-specific estimates into a meta-analysis. So this was the first look at the effect of overweight and obesity in the severity of COVID-19. So I know that these plots are very, very hard to read because they're very small. But what I will say is we divided the groups up into overweight individuals and obese individuals. So overweight individuals are typically those classed with a BMI of 25 to 30. This does vary a little bit based on the ethnic composition of the population. And then those who are obese are 30 to 35 typically, and then you have those who are morbidly obese and so forth. And what we found is that both overweight and obese individuals, adjusted for all those other confounding variables, had a significantly increased risk of non-invasive ventilation and invasive ventilation when infected with SARS-CoV-2, but they did not have a significant increased risk of mortality. So what we did is we looked at the impact of diabetes independent of BMI on these outcomes of SARS-CoV-2. And what we saw is that very much diabetes increased the risk of non-invasive ventilation, invasive ventilation, but again, it didn't increase the risk of mortality. So there's certainly good evidence that both diabetes and obesity and overweight are independent risk factors for severe COVID-19. Now, one of the questions we had on top of this is what happens if you look at a sort of additive effect? So what we know is that a large number of individuals with type 2 diabetes are either overweight or obese. And some individuals with type 2 diabetes actually develop diabetes at a healthy BMI. So what we wanted to know from our data is, are patients with both diabetes and an increased risk of BMI at heightened risk of severe COVID-19 compared to those with diabetes and a normal range BMI? So that's exactly the analysis we did. And surprisingly, what we found is that of the individuals with diabetes, either overweight or obesity did not increase the risk of any of our outcomes of disease severity. So we think that these data have really important policy implications. And the first thing I would really emphasize is that sort of until this study, there was really only single site studies available. And this was the first big international study. And we tried our very best to include low and middle income countries. This was somewhat difficult, but we got at least a few in there. So trying to make this as globally representative as possible. So what we would suggest is that both overweight and obesity should be considered important risk factors for severe COVID-19. And I think that a lot of people focus on obesity, and certainly a lot of policy recommendations focus on obesity, but we forget that overweight can be almost as bad. We suggest that patients with diabetes don't need to be further risk stratified according to their BMI. And really fundamentally, and this is something that we've known from flu pandemics for a long time, that addressing the global obesity epidemic is an important part of pandemic preparedness. So this was all looking at those respiratory complications of SARS-CoV-2 infections. But we also know that SARS-CoV-2 causes a variety of extra respiratory complications. And in particular, these encompass cardiovascular disease. So there's a variety of different evidence showing that SARS-CoV-2 across all individuals increases the risk of cardiovascular disease. But what we know from this study in influenza, and now we're swapping to influenza-associated cardiovascular disease, is actually underlying diabetes increases the risk of this extra respiratory complication. So we wanted to see if that was the same case for SARS-CoV-2. So we did a meta-analysis on the studies that were available. And indeed, we found that diabetes significantly increased the risk of acute SARS-CoV-2 cardiovascular complications. So this was very much during the acute phase of COVID-19. What we also wanted to do is sort of look at the long-term complications, because there's now this growing awareness that SARS-CoV-2 infection has long-term complications, one of which is cardiovascular disease. And we sort of reasoned that perhaps patients living with diabetes were more at risk of these simply because they had underlying chronic health conditions. So we've got a cohort of patients who've recovered from SARS-CoV-2, and we've collected serum from them at various time points. And this is just looking sort of 2 to 3 months post-infection. And this is looking at elevated levels of CK&B. So it's a bit of a non-specific marker for cardiovascular damage. But what we were really, really surprised is across all our risk groups, so this is chronic respiratory disease, diabetes, hypertension, cardiovascular disease, and our patient group that didn't have any underlying conditions, what we can see is really all of them have some level of elevated CK&B in their blood 2 to 4 months post-infection. Now, that's 100% of the 5 patients we were able to recruit with diabetes, but it's more than 80% of our control population. So we're still very much expanding our recruitment here. And one of the things that we're going to be looking at is how does this look at 6 months? And we're just collecting the 6-month samples now. How does this look long-term? And is it something that patients with diabetes who've recovered from COVID-19 need to be monitored for these extra respiratory complications many years after the infection has resolved? One of the really interesting questions that has come up in this pandemic is fundamentally there a difference between individuals with type 1 and type 2 diabetes? So very, very early on, and I actually think throughout the pandemic, often in clinical studies, people have just been recording patient information as diabetes, yes, no. But of course, we know that type 1 and type 2 diabetes are really fundamentally different. So initially, and I would say probably until end of last year, early this year, there was a general consensus that this was much more severe in patients with type 2 diabetes than it was in patients with type 1 diabetes. And there was a large body of evidence commenting on why they weren't seeing more patients with type 1 diabetes coming into hospital with severe COVID, whether it was a coincidence, whether it reflected better glycemic management in this population, it was not clear. But now there is really a growing body of evidence that both type 1 and type 2 diabetes increase the severity of COVID-19. I think there's probably not quite enough evidence to suggest whether one is worse than the other, but certainly both are emerging as risk factors. And then another interesting observation that has come to light more recently is there's also a subset of patients where type 1 diabetes onset seems to be triggered by COVID-19 infection. So what is it about diabetes that increases the severity of COVID-19? And this was really a fantastic study that came out of China that looked at about 7,000 cases of patients with COVID-19 and diabetes. And what I should say is that the vast majority of these patients were type 2 diabetes. And what was interesting is that when you compared their diabetes population to their healthy control population, there was actually no significant difference in body weight. So for whatever reason, we didn't necessarily have obesity as a confounding factor in this study. And what they found is that amongst these patients with type 2 diabetes, those with well-controlled blood glucose actually did pretty well, whereas those with poorly controlled blood glucose typically were the individuals who succumbed to disease. And this has just been verified with a more recent study in diabetes care, saying that when we look at individuals with mortality, we can see an association between glycemic fluctuations and their risk of severe COVID. So I just want to touch on that a little bit, because I think this is probably something that if you're not in the diabetes field, you might not necessarily be aware of. But in healthy individuals, throughout the day, we have these variations in blood glucose levels. And that's typically when we eat, our blood glucose goes up and then it gets brought back down again. And it's kept within a relatively stable range. But when we look at patients with diabetes, and particularly those with uncontrolled diabetes, what we see is that these fluctuations not only become more extreme, but they also become more frequent. And we've been working in the context of influenza for several years now, thinking that probably these extreme fluctuations in blood glucose levels are part of what is affecting their susceptibility to viral infections. So I'm a basic scientist by training, so I have to present you some experimental data. This is a mouse model that we set up for glycemic variability a year or so ago. And essentially what we do is we take obese mice, so we're modeling type 2 diabetes, and we implant them in with a glucose pump. Now, this glucose pump releases a constant amount of glucose throughout the day. So they're not getting these fluctuations in glycemic variability levels, as you can see here, but they are getting a sort of glucose infusion. In our glycemic variability group, what we're doing is we're implanting them with this PBS pump, and then we're giving them glucose injections throughout the day. So this bolus of glucose, and that's causing their blood glucose to fluctuate throughout the day. Now, what's really interesting is if you infect these mice with influenza, what you see is that the variable group lose significantly more body weight, have significantly worse blood oxygen saturation, and have significantly more inflammation compared to the mice who receive that constant glucose. So what's really important to note here is that these individuals, they have the exact same level of the exact same amount of glucose that they're receiving. It's just that one is fluctuating a lot and then the other is not. So why is this relevant? Well, this is particularly relevant because we live in a world where undiagnosed type 2 diabetes is particularly prevalent. So for example, in South and Central America, 2 in 5 people with diabetes are undiagnosed. In Africa, it's 3 in 5. So this is really, really a problem because if you're not diagnosed with diabetes, you're not receiving the appropriate treatment, and therefore you're more likely to suffer these glycemic variations and potentially more likely to suffer from severe COVID-19. So there is also some interesting evidence for metformin. Now, metformin is a drug that's used to treat patients typically with type 2 diabetes. And there's an emerging body of evidence that metformin treatment may actually be beneficial in patients with COVID-19. And it's a bit hard to say whether this is related to controlling some of that glycemic variability or whether it relates to the immunomodulatory effects of metformin. And certainly there's some questions in my mind about what metformin will do in terms of long-term immunity to SARS-CoV-2. But it is an interesting interaction between a common diabetes drug and severity of COVID-19. So finally, I just want to touch on obesity. And, like I said, there's a lot of complex overlaying factors here with obesity and diabetes. But we do know that patients who are obese and certainly not living with diabetes or have pre-diabetes are still at risk of severe COVID-19. And this could be through a variety of different mechanisms. We know that obesity completely alters your immune response, and typically you have a more pro-inflammatory immune response and a poorer antiviral immune response. We know it increases the immune response of your endothelial cells. So this makes you start thinking of the coagulation that's been well described in COVID-19, as well as decrease in pulmonary function, and then causing a whole lot of other complications. So it's not surprising that we're seeing obesity and diabetes emerge as risk factors. So I'm going to end it there so people don't have to listen through my bad internet connection. But what I will say is that really the lesson that this pandemic should have taught us from this perspective is that until we address the burden of metabolic disease in our society, we cannot consider ourselves prepared for the next pandemic, because this is going to be a problem that comes up again and again and again, especially as more and more of the population are living with these chronic medical conditions. Thank you very much.
Kirsty, thanks. Terrific. And just while it's front of mind, Kirsty, but are humans anything like your mice in that? What about intermittent fasting? And is that going to be bad for us in times of respiratory viral infections?
Yeah, it's a really interesting question. There was actually a study done, I think sometime last year, where they actually put mice on a ketogenic diet, believe it or not. And they found that the mice on a ketogenic diet did actually much better with influenza than the mice that were just on sort of standard chow. So maybe it's we can't always extrapolate from mice to humans, but I think diet fundamentally has such a big role in viral susceptibility.
Thank you. There's a question just on, while we're talking about susceptibility, the issue of pregnancy and susceptibility, and from all three presenters, in fact, got any thoughts about that?
So initially, certainly in the pandemic, pregnancy was not emerging as a risk factor, not to the same extent that it was in the 2009 swine flu pandemic. But I would say now there's a bit more evidence of an increased risk of preterm births. There is some evidence of increased risk, but I would still say it's probably not the same extent as what was seen in 2009. I don't know if the other panelists want to add to that.
Jodie, have you seen any data?
No, I would just go with what Kirsty's saying. Yes, it's certainly not been as marked as for H1N1, but still a concern.
Rhema, can I ask you about low trust communities, and particularly, say, in Australia? Can you characterise, when it comes to digital technology, are there discrete groups, or does it really just go across the spectrum of the Australian population?
That's a great question, Lou. I don't think I've seen any actual evidence on how to identify who the low trust communities are in Australia. I would suggest they would be Indigenous communities, immigrant communities, communities who feel like they're not always getting a fair shake. But when I think back to what the data commissioners report, I think they hadn't identified specific subgroups. In our work in New Zealand, we've definitely identified Pacifica Maori communities, and also families who've had a lot of contact with the criminal justice system, with child welfare systems which are sort of punitive. They tend to sort of feel like their data might be being mistreated. But on the other hand, I've also done work with homeless people, and sometimes they have a lot stronger benefit from the kinds of systems and data sharing that we're trying to do. So I think sometimes when people are low trust, they can also see a lot of benefits as well. So it's never just a question of whether they trust the digital technology. It's also about whether they can see benefits from it. So you can be quite surprised to see some communities who you would kind of characterize as low trust still coming out quite strongly in support of some of our digital approaches, because they themselves can see high levels of personal or community benefit for themselves. Whereas we try to look at education, and it's often the middle classes who are very averse to any interventions, any digitization of education type approaches, just because they don't see a personal benefit for themselves.
Do you think we should regularly measure it in the community, and then potentially Jodie could use the data to model, you know, the likelihood of uptake and efficacy of different programs, particularly vaccination?
That's a very good question, Lou. So I'm not a fan of kind of quantitative approaches to social license. I actually think the only way to develop a program of social license is to have rich conversations and use qualitative approaches. And there are participatory democracy type, participatory design approaches that we've used and found very powerful. They're very time consuming, but I think those are the approaches I would use for understanding community comfort, as we call it, rather than these sort of I'm very critical of these very sort of singular questions. How comfortable are you? It's so contextualized. It needs a rich conversation. People need to understand the benefits really first before they give an opinion.
So Jodie, how robust does a measurement need to be before you can use it to model? So Rhema's concerned that we wouldn't be able to actually accurately measure community engagement with technology.
I agree with her. I think it's an iterative approach. And I think, you know, one of the key learnings around the world, I know, you know, we saw so many countries like Singapore that did really well at the start of the pandemic, and then they had their migrant worker outbreak. And many of us were saying, where's our Singapore? And then we had the second wave in Victoria, and we saw about an outbreak that emerged in many called communities and less socially and economically advantaged communities, in tower blocks. People who were essential workers, and we saw the groups who were at ongoing risk because of contact, but also had been less reached and less engaged. And so I think in that way, the quantitative data showed very clearly where the gaps were. The strategies then to engage those communities and to work with those communities became absolutely evident that they were critical. And I think then a lot of work went on at that community level. And actually, I've heard Nari Blow talk about the work in Victoria based on First Nations principles of going back to communities and working with a range of called communities. So I think it's working out what you use what for. We could certainly say you've got to go and sort this out. And I think it's still a recognition that we look very carefully at the characteristics of early cases and outbreaks to understand what the risks are in terms of outbreak potential. We saw, you know, northern beaches, which could be isolated, and, you know, people's biggest concern was, how am I going to eat all the food in my fridge because now I don't have a Christmas party, to these other communities. And so I think we can use those insights to try and draw things together. But I agree, the solutions are community engaged and community driven.
So there are questions in the chat about modelling regarding border closure and also testing before flying overseas.
Yeah, so I made a comment on some of these, but, you know, I guess as we saw from the very early epidemic data, we were able to use mobility as a way of thinking about source prevalence. We certainly can, you know, make predictions, or not predictions, we can look at relative risks of exporting cases based on community transmission and prevalence. And, you know, we see that play out even in our hotel quarantine system. We see how many of the arrivals are coming in who are infected from different source prevalence countries. When Victoria had its second wave, clearly it posed a risk to the rest of the country. And I think now we see many of these policies used in different ways to support local jurisdictional efforts that are less quantitatively driven and more about the way we've come to deal with COVID. But, you know, things like pre-flight testing, I think we need to see that as part of the Swiss cheese strategy of how do we continually try to reduce risk. Clearly, a test will not exclude an infected person who is pre-symptomatic or not yet shedding enough, or who has a test of imperfect sensitivity. So it's not a guarantee, but it's another risk reduction measure, you know. So it really fits into that end-to-end approach that we're trying to take to find those final chinks and try to reduce risks further.
And Jodie, you must have many people coming to you with ideas, you know, can you model this, can you model that, you know, if we did this, if we did that. How do you decide? Do you have to put a limit? And do you get cross if they don't pay any attention to the result?
Look, I think, you know, it's been an extraordinary year for modelers, and James McCaw and I being invited onto the Australian Health Protection Principal Committee has been an incredibly privileged position to understand emerging needs and questions as they arise, and when we do feed modelling back, to see how that's received and interpreted. But we're only one source of evidence, and I think an important part of communication with decision makers is saying, well, this is a logical question, this is a political question, this one, it's a little less clear, and a model can help to support your thinking about this using quantitative means. But a lot of the modelling we do is actually very strategic. You know, it's about future laboratory testing strategy. How do we make use of new tests and approaches? It's putting a quantitative framing around things. And if you do it well, everybody goes, oh, well, that was obvious, right? Because it makes sense, but it's actually putting a principled framework around it that helps people to think about and differentiate those outcomes. So I think, yeah, there'll be a question. Sometimes we'll say, you don't need a model. Sometimes we'll say a model can't help you. Everybody wants a threshold or a target or a trigger. We'll say, try again. But, you know, it's a dialogue, and it's seeing it as part of a way of using and synthesizing evidence.
Thank you. Kirsty, the ACE2 receptor as a sort of the way of the virus attaching to respiratory epithelium has been investigated a lot. Is there any correlation between obesity, diabetes, and the ACE2 receptor frequency on epithelial cells?
Yeah, I'm quite skeptical of blaming a lot of this on ACE2 receptor density. And the reason for that is that, yes, ACE2 is a receptor for the virus, but ACE2 physiologically also plays a really, really important role in an anti-inflammatory response and an anti-fibrotic response. So I don't think it's as simple as saying there's an elevated level of ACE2, say, in patients with obesity, because whilst that may mean more attachment sites to the virus, it can also mean more immunomodulation, less fibrosis, and actually beneficial things. So I think it's, you know, these are things that we look at, and these are things that we can investigate and find statistical significance with. But I think physiologically, it's much more complex than that.
Thank you. Final question to everyone. Rhema came up with the mantra, the need for speed, which was actually touched on yesterday too in terms of leadership and decision making. And so my question for each of you is to, in your own particular of expertise, you know, where's the prime need for speed? Rhema, first.
Okay, so I think as we look forward to a vaccination strategy, my concern is that we're going to have a reliving of the same thing where we get pushed into, there are digital approaches to vaccination prioritization and machine learning kind of approaches and data approaches. And I'm worried that people will rush to those kind of technological approaches without checking under the hood and being really careful about it. So I suppose I'm saying more need for less speed and more caution when it comes to reaching for kind of novel approaches to vaccination prioritization strategies.
Thank you. Jodie, the need for speed in modelling?
Yeah, so look, I think it's about ongoing evaluation of emerging evidence and trying to synthesize that as well as we can into existing models and working out when we're going to need to change them as we see new variants, as we think about vaccines and strategies. And I think, you know, in the conveying of that back to decision makers, it's that ability for them to change the state of play and to you know, adaptively do that. I think in the UK, we've seen very delayed decision making in the face of overwhelming evidence of the need for change. And then we see how far further there is to catch up when you let this virus get away. So, you know, we have to work with the best we have. We have to make those insights as quickly as we have, and they may be imperfect, but we can't afford to sit on this virus. And I think in Australia, we've been fortunate that we've had, decisive decision making.
Kirsty, in your area?
I would say maybe not need for speed, but need for priority. And something that I think we really need to understand is the long-term or the longevity of vaccine-induced immune responses in vulnerable populations. Because what we know from influenza is that both diabetes and obesity actually decreases the longevity of the host response to vaccination. So there's a question there for me. Are there going to need to be boosters, not just because of variants emerging, but also in subsets of the population?
Thank you. In closing, I'd like to thank all three speakers. You have very clear descriptions of important issues to do with COVID. Kirsty, thanks for tolerating and making up for a difficult internet connection.
Wonders of Zoom.
And thank you for answering, everyone for answering the questions in the chat.